welcome. It is June 11, 2024. I'm Dr. Deuk, and our patient travels here from Puerto Rico. He has had a fusion on his spine before at T10-11. Is that correct? So you can see that at the bottom of his x-ray. We're not going to mess with that area. We're actually going to be going up higher. He's having pain at T5-6. We got to find the T5-6 disc. We're going to repair it. So let's start with an AP view. For thoracics, we want to start with AP. We want to count from the first rib down. So we're going to start at T1, and then we're going to go down to T5. All right, Jordan, very good. So let's find that first rib. That looks like it right there. So let's see if I can find it, Sean. So a little bit higher here, Sean. That's it, right?
Yes, sir.
I think that's the first one. I think that's T1. So if that's T1, then there's T2, 3, 4, 5. And then, okay, so it looks like 5, 6 has a funny nose. Look at that. Show us the funny nose. See that, guys? The funny nose? Show us the eyes. There's the right eye. There's the left eye. There's the funny nose.
Looks like a dachshund face.
Right?
Yeah.
Let's see if I can find it. Sean? That's it. Right there. Sean? It should be pretty close. We're going to verify it, of course. So, our patient is asleep. He's under propofol sedation, so it's twilight. We're going to actually ask him to wake up in a little bit. We're going to verify that the pain he's having is where we're working. But first we got to get there. That's going to take us a minute. So if you have questions. For those of you who don't know what we're doing, we're fixing a disc. This patient has a painful disc in the thoracic spine. It turns out we're probably one of the few places in the world you can go to get those addressed. Shot? All right, let's do a lateral and see where we are. 1, 2, 3, 4, 5, 6. Everybody agree we're doing a right T5-6. You can see the metal plate in his neck as well. Henry, you see the plate up there?
Yes, we do.
Yeah, so he's had a lot of spine surgery in his neck, his lower back, but nobody could touch his thoracic. But he found the Deuk Spine Institute, and that's what we do. We can do thoracic procedures. All right, it looks good. I'm lining up nice on a disc. And Jordan just fixed the orbit. That looks really good, Jordan. I may need to be a little higher if that's 5, 6 in front of me. Folks, we're coming in from the back. The back is where you saw the needle. I'm repositioning already in anticipation. Shot. Uh-huh. All right. Shot. Here's his midline. I'm just off the midline. Shot. You're doing all right. Give me an AP view. I'll try to give him a little numbing, but let me just make sure we're in the right spot. When you have so many discs as we do in the thoracic spine, it looks like we are in the right spot. So there's T1, let's count. T1 pedicle, 2, 3, 4, 5, 6. So we just counted the pedicles and we're lined up perfectly with the T5-6 disc on the right side. I'm going to give my patient a little more numbing medicine, and then we're going to work on getting into the disc so we can repair it with the Deuk laser disc repair. Anybody wondering, well, what is it that we're doing here? We're trying to get rid of his pain he's having in his thoracic spine. He's having pain from a disc injury. Very common problem. Lots of people get disc injuries. There's the facet. Yeah, lay still. You're doing great. We're almost done. We're going to put you to sleep in a minute, okay?
You're doing great.
Lay still. Don't move. You're doing great. I think I'm too medial, Sean. I'm hitting the facet. I have to redirect. He's got some arthritis here. Jordan, one more shot, then AP. So I'm hitting his facet joint. Let's go AP. Let me just see what I need to do to get around it. Otherwise, I like our trajectory. Any questions?
Yes, we have a question from Sherry on Facebook
Hi, Sherry. How are you?
asking, hello, everyone. Where have you all been? Nice to see you back.
It's good to be back. Well, the truth is, 1, 2, 3, 4, 5, 6. Truth is, I was gone last week. My daughter graduated, and I was with her on a trip to see her off to college. Shot. All right. Shot. All right. So, but we're back. Where do you feel that, Sean? AP. Jordan, what do you think? Are we off on orbit there, or are we good on orbit, you think? Damn, that looks pretty good though. Yeah, I like it. So, show us the interpedicular line. Can we get rid of that X? Yeah, the interpedicular line, Jordan's going to show you the pedicle at 6. Go to 6, yes. And then go up to 5. Yep. So from the middle of 5 pedicle to the middle of 6 pedicle is the interpedicular line. And we are right there with the needle. So you can see the lung fields look good. There's no pneumothorax. We haven't dropped the lung, which is always a risk with these procedures, is having the lung drop. All right, we're almost there. We'll be ready to do our evocative diagnostic procedure. Just a minute. Just hang in there another minute, okay? Lay still, you're doing awesome. Are you comfortable?
Doing okay now? Okay, good.
Are you comfy? Are you comfy? How long have you had this thoracic pain for?
5 to 6 years.
And you never had it before 6 years? Or did you have it less commonly? Thoracic pain, let's just say he said 5 to 6 years. So he's had this pain for 6 years. You having any pain right now? No?
Keep your arms nice and still.
How bad is that on a scale of 1 to 10?
What would you give that? Give us a number.
9.
9.
Is that where you get your pain? I couldn't hear him.
Yep.
All right. When you wake up, that pain will be gone. So folks, we just did a confirmation test. You know, I don't like to do any surgery unless it's going to help the patient. Of course, who knows ahead of time if a surgery is going to work or not? We don't. But we learn from our experience whether it's going to work. And at Deuk Spine, we have a very, very complex algorithm for figuring out where people's pain is coming from. And we identified T5-6 to be the source. So there's no MRI that can tell you pain's coming from here. But we just did a discogram, and he said, yes, that's where my pain is coming from. And it went up to a 9 out of 10 when I injected it, which is really good. All right, shot. Next is going to be removing this needle and leaving the guide wire. Then I'm going to make an incision. Now the incision is 4 millimeters. And we're going to go in and basically do the Deuk laser disc repair with a tiny little 4 mm tube. Okay? The surgery is, as you can see, you lose a few drops of blood, but that's it. It's not like major surgery where you're losing liters of blood. We don't do any transfusion. Jehovah's Witnesses love us. Shot? Because we don't have to do a transfusion. Obviously, this is not risk-free surgery. There's always a risk of having a complication, and the complication with, who is that? Her?
Yes, that's me.
Please don't make noises. There's always risk of complications with spine surgery. Any questions?
Yes, we have a question from Rita on YouTube
Hi Rita, welcome back.
asking, can you do without steroids if the sky's open? I got shingles from steroids, and also congratulations on your daughter. Good for her. Hope it was a nice time.
Oh, thank you. I didn't understand. All I heard was, can you do this procedure without steroids?
Yeah, that didn't even mention the procedures. Like, can you do without steroids if the sky's open? I think that isn't titling for. Can you do this surgery without steroids?
Hold on. It's a great question because we give steroids for patients that, to prevent nausea, post-operative nausea, right? And I don't know. How important is steroids? We can do it without steroids, I'm hearing. We have in the past. We can do it. Not a problem. All right, I'm going to advance the dilator.
I can give other anti-nausea meds too.
Tube. Next.
Your sedation is you don't have as much nausea.
So yes, we can do it without steroids. We're going to advance the tube. The whole surgery is done through a 4 mm tube. Okay? Everything we use is FDA approved. All right. We're just outside the disc. I'm going to advance this. There you have it. We're doing the entire surgery through this 4 mm incision. We've lost probably 10 drops of blood. We're about half a cc at this point. A cc is a milliliter. Most spine surgery, you're losing 100 to 500 cc's of blood. We're losing maybe 1 cc. So compared to other types of spine surgery, this is a much safer, less bloody procedure. We've done a lot of thoracic cases now. I mean, when I say a lot, most neurosurgeons will do just a couple in their entire career. And we've done about 30 or 40 now endoscopically. And I've done obviously more than that before I started doing these endoscopic. I've done a lot of trauma. Most thoracic type surgery of the spine involves trauma, motor vehicle accidents, fracture dislocation, or tumors that affect the spine, such as metastatic cancer or infections, fractures, tumors, infections. So it turns out that a lot of thoracic spine surgery is done by specialists that specialize in trauma or tumor or infection. But there are degenerative conditions that affect the thoracic spine, like this patient's, where you have a disc problem. And I can clearly see that this disc is damaged, and it is definitely the source of his pain. Now, he could have other discs causing his pain. As a matter of fact, for him, we recommended fixing both sides, but he chose to only do one. I think he's going to get really good relief. I told him, well, when you don't do everything I tell you to do, you're probably not going to get 100%, but you should get about 75%. He was happy with that. Now the other problem this particular patient has is having neck pain. And remember, he's got a fusion in his neck, right? We showed you that metal plate earlier. You guys remember that, Henry?
Yes, we do.
So what's happened now, he has what's called adjacent segment disease. What is that? Adjacent segment disease is where you have a problem next to a fusion or artificial disc. It's basically a problem at the next disc or next joint adjacent to where you did surgery. The surgery he had in his neck was a cervical fusion. And you put a plate and they fused 2 discs. So now he's got pain below that. And we're going to go in and treat that. Any questions?
No current questions, but we do have a comment from Rita, once more on YouTube, saying, I got shingles from steroid shots, meant if a miracle happened and I could get to you for my back and knees.
I understand. Yeah, shingles, for those of you who don't know, is herpes zoster. Herpes zoster, right, Berndes?
Yeah.
Infection. And
Varicella zoster, which is chickenpox, herpes zoster. As you
Yeah.
age, it goes into the
VZV.
Yeah.
And what it is, it's a viral infection that we all get chickenpox as kids. And
And it hangs out in the dorsal root ganglion.
yeah, the virus never really leaves. It invites itself into your body and then it just stays.
And then when you get immunosuppressed, such
Yeah.
as steroids, medication, stress,
Yeah,
lack of sleep, or diet,
it comes back out.
or even other illnesses.
And it literally can hide in your nervous system within the dorsal root ganglia of your nerves for years, 10 decades.
People in their 50s can get it, or people 80 can get it.
Yeah. And a lot of times people don't even realize it's there until they have an outbreak. And the outbreak is caused by stress or could be even steroids.
It's usually in the thoracic dermatomes, but it can get in the face, facial nerve, and
Yeah.
usually thoracic.
Yeah. It's cold sore. If you ever had a cold sore, that's an outbreak. On your lip or your nose, those are the same virus reactivating from the trigeminal dorsal root ganglion, or trigeminal ganglion, I should say. It's not really dorsal root. Anyway, any other questions?
No current questions, but just another comment from Rita, once more on YouTube, saying, was because I'm immunocompromised Takayasu.
Right, of course. Yeah.
If it's in a thoracic spine, would it be dorsal root coming out of the...
Yeah. Yeah, thoracic dorsal root. But for the face, it's trigeminal. The face is actually very common. And so many people have cold sores. They call it a cold sore. It's actually a ulceration from herpes.
Simplex one.
Probably 5 minutes, maybe 8. There's some inflammation, some redness. So we're gonna finish this and then we're gonna end the broadcast. We're gonna come back with a cervical bilateral DPR. This patient doesn't just have the thoracic pain from this herniation, annular tear. He also has pain in his neck below his fusion that is originating from the facet joints. Good call on the tube size, Luis.
Yes. What's
Hmm?
the team call? I asked DT, I asked Jordan, I asked
Whatever, you made the right choice.
yeah.
It's perfect. You can see bone to bone. That's what we want. Henry, anything you want to show the audience?
We can show them the... Great question.
Do we have a thoracic DLDR video?
Oh, no, unfortunately, no.
Not a educational video, but what about a
Oh, a testimonial?
testimonial?
Oh, yeah, 100%. We definitely do have that.
Let's see if there's any questions, and then we'll do that. But basically, everything's going well. And you know what? Why don't we use that? Oh no, we're going to end the broadcast. So If there's no more questions, we're just about finished. I'm just cleaning this residual disc herniation stuck inside the annular tear. And it's going to take me about 2 more minutes. And we're going to end this stream. This should fix his thoracic pain. We'll be back in a few minutes to do the cervical. Okay? This should be the last bit. How do you know you're getting to the end? Because you can see the redness. Sometimes you can see fat, epidural fat. We're at the back of the disc right now, and the back of the disc is the end of the disc. So that means we're just about finished. I can tell because there's some redness, there's more scar tissue. You can only get scar tissue where you have a blood supply. Cannot get scar tissue where there's no blood supply. So the fact there's more scar tissue here tells me there's more blood supply, which tells me I'm at the back of the annulus. I'm at the periphery, the outer part of the annulus. That's where there's the most blood supply. So I use these little cues. That's the last of it right there. So his case went really well. Stable?
Yes, it will.
He's stable. We're going to keep him asleep while we fix his neck, and then we'll wake him up, and he's going to go home in an hour. So. Any other questions?
Our first case.
At this moment, no current questions.
So today he's from Puerto Rico.
Yep.
We had another patient from Trinidad and one from, well, Korea. So yeah, it's the Day of Islands.
He lives in Seattle.
I had a patient from Hawaii 2 weeks ago. She gave me a beautiful necklace after surgery,
Oh, that's cool.
made
My son was
from,
Hawaii.
really? Like permanently?
Yeah, he's been there almost 2 years.
Oh.
Honolulu.
Honolulu.
I never seen it. Too far to fly. Can't get over it. It's 13 hours.
It's too far. It's just too far. For me, I like,
He doesn't like to fly, so
he doesn't like to fly.
I haven't
Your
seen him in
son?
2 years.
All right, Henry, I think this is it. These are the last chunks, hopefully.
Copy
We're
that.
just about done. Is there any other questions?
No current questions.
All right, so go ahead and we can end the stream,
Copy that.
and we're going to switch over in a minute to the DPR. Just want to take one more look. A lot of calcium here. Oh yeah, there. Epidural stuff. All right, that should be it. Let's clean it out. You can go ahead and end the stream, but if you want to see the incision, 4 millimeters. We lost, let's just say 1 mil of blood. We're going to irrigate in case there's any loose pieces, and we'll put a little antibiotic medicine in there, which is pretty standard stuff for surgery, to irrigate with antibiotic medicine.